So this is an abstract that we submitted on 2 consecutive trials in older patients with acute myeloid leukemia over the age of, the vast majority over the age of 60 at diagnosis. And one of the questions we wanted to try to answer was the role of reduced intensity allotransplant in first remission of these patients. The options for patients who achieve a remission, and certainly over 2/3, about 70% of patients, older patients, will achieve a remission with intensive chemotherapy. There are options for, we know these patients are at high risk of relapse, particularly if they are flow MRD positive post-course 1. So the options for these patients include further consolidation chemotherapy. An emerging option is that of maintenance chemotherapy. And a third option is allotransplant, reduced intensity conditioning. And the purpose of our abstract was to try to evaluate the role of RIC transplant in these patients. So we looked at 2 consecutive trials, the NCRI AML18 trial and then the subsequent AML18 trial, which is still actually ongoing, although the part that I'm talking about was completed 18 months ago. We found that in AML16, about over 930 patients achieved a complete remission, of whom just over 100 actually had a reduced intensity transplant. So the transplant rate was quite low. This trial actually finished several years ago now. So the analyses are, we've got quite long follow-up on these patients. So the transplant rate was about 15% in AML16 and increased to over 30% in AML18. What we found was that there was a survival benefit for patients having reduced intensity transplant that we saw in AML16. So if we look at the patients alive, overall survival at 5 years post remission, the 37% of patients with having a transplant were still alive compared to 20% with those without a transplant, and this was a highly significant difference. And this benefit was due to reduced risk of relapse in patients, which was more than halved by a reduced intensity transplant. The downside of a transplant is the risk of treatment-related mortality, and this was increased in the transplant arm. So the survival benefit was not as great as one would have liked, but still significantly better than no transplant. We then tried to break down and ask the question, is this benefit for transplant just purely because we're selecting patients who have a better outcome for transplant? So we took into account a variety of factors, including their age, their performance status of diagnosis, cytogenetics of diagnosis, and the white cell count of diagnosis. And even taking into account these factors, we couldn't find a group of patients that didn't benefit, whether they were good risk for these features, standard risk for these features, or poor risk for these features. All the groups seemed to benefit. We also looked at their MRD status and the benefit, whether they were MRD negative or MRD positive remissions. And we found that benefit was equally distributed. In other words, there was no difference in benefit of transplant. So when we moved on to the AML18 trial, the follow-up is not as long as for AML16. We've again repeated that analysis. And we found that this benefit for transplant holds up, so that at 3 years, the survival of patients having a RIC transplant was 44%, compared to 34% for those patients not transplanted. And again, this was due to a significant benefit in terms of reduction in the risk of relapse. What the interesting thing about the AML18 trial was, again, the benefit for patients with an MRD positive or MRD negative post-course 1 stood up. So again, we saw benefit whether they were MRD positive or MRD negative. But we then looked at the outcome for those MRD positive patients when they were after post-course 2, when they had subsequent treatment. And then we asked the question, was a benefit seen in those patients who converted from MRD positive post-course 1 to MRD negative post-course 2? And what we found was that the benefit was most clearly seen in those patients compared to those who remained MRD positive. However, we cannot exclude a benefit for those that remained MRD positive, but the benefit was greatest in those who switched from MRD positive to MRD negative. And this seems to support the concept of the treatment intensification in the trial, which was used to try and convert these poor risk MRD positive patients to MRD negative. And there we can see the greatest benefit for transplant. So that, in a summary, is pretty much what we found in this presentation. But we're going on to analyze if we can identify different genomic groups, different genetic groups of AML that benefit most clearly. And that's an ongoing project at the moment, and we should have data on that later this year.